Hi guys, I'm talking today about pediatric anxiety, substance-induced pediatric anxiety versus independent anxiety, management of anxiety on behalf of the NP in the primary care setting, and opinions on whether the NP, how far the NP should be going in terms of treatment for these anxiety disorders. So I found some pretty good resources for information on these two disorders and tips on management. First was from the American Osteopathic Academy of Addiction Medicine. They highlighted some differences between substance-induced anxiety versus independent anxiety disorders, which were first differentiated in the DSM-4, and the DSM-5 has kept the same differentiation. So in addition to diagnosing anxiety in the first place using quality and quantity of episodes and patient history, the criteria for differentiating the cause of anxiety includes a couple key points. So to diagnose mood or anxiety disorders, the full syndrome is established prior to substance use. The mood or anxiety symptoms persist for more than 4 weeks after cessation of substance use. Whereas with substance-induced anxiety, there's evidence from the history and physical or labs or both of intoxication with a substance, withdrawal from a substance, or onset of use of a substance. The disorder must develop within 1 month of substance intoxication, withdrawal, or onset. The involved substance or medication is capable of producing that mental disorder, and the disorder is not better explained by an independent mental disorder. But the symptoms may be the same in both disorders, which is why the history taking component is so important. A couple different meds that we see pretty frequently in the pediatric setting that can cause anxiety include bronchodilators, like for asthma, that we see especially in our pediatric population, anticholinergic medicines, even insulin, which I was surprised to learn, thyroid medicines, oral contraceptives, antihistamines, which can have a paradoxical effect in children, can actually make them overly excited, whereas in adults makes them very drowsy. Corticosteroids, which we all know about, anticonvulsants, lithium, antipsychotics, and antidepressants. Those last three kind of imply that there is already an existing anxiety disorder, so that would be a little bit more difficult to tease out whether this new anxiety disorder is brought on by the medicines versus an independent or concurrent anxiety disorder, which may necessitate more of a referral than simple management in primary care practice. Substances that can cause anxiety include alcohol, caffeine, cannabis, and tobacco. In terms of managing pediatric anxiety in the primary care setting, it's really important to know just how common anxiety is in the pediatric population. I think it's estimated that around 6% of kids are diagnosed with anxiety disorders, and there's a whole group that don't even get diagnosed, either because of cultural limitations or parental concerns that they don't want their kid to have a problem, and so they don't really bring it up at issues. So at visits, so the primary care NP really has to be quite astute in picking up on these things and using some screening tools and making sure that these kids get the resources that they need. The median age of onset is 11 years old, and it is the most common emotional disorder of childhood. A qualitative study that I read surveying 20 primary care practitioners found that in general, practitioners feel very ill-equipped in managing pediatric anxiety in the primary care setting for a variety of reasons. Their uncertainty centered around 3 themes: diagnosis uncertainty, how to prioritize this anxiety disorder in relation to physical illness, and how to manage and when to refer. Many practitioners were uncertain how to tease out the root cause of anxiety, if there's any, so that really involves a thorough history taking and being aware of some of the less common causes of anxiety and family changes. Management includes referral to psychotherapy as first-line therapy, such as cognitive behavioral therapy has been shown to be very effective. And also NPs, depending on their comfort level, of course, can prescribe first-line treatments for anxiety, which you mainly see SSRIs, sometimes SNRIs, and TCAs. NPs also must work to gain the insight into a thorough history to ascertain possible underlying causes of anxiety, and if those are modifiable, then you can sometimes correct those causes and thus fix the anxiety. Like if a child has anxiety and you end up talking to them and they state that they can't focus during school, or maybe they complain that the letters are changing position and so they're having trouble reading, that of course would cause anxiety in a school-age child, falling off the learning curve, but it may be an underlying attention deficit disorder or dyslexia. The history could also uncover physical conditions that could be accounting for the symptoms, like thyroid disorders or chronic pain, like juvenile RA. Those certainly, if you're in chronic pain, or if you have an intrinsic problem with your thyroid that's causing you anxiety or pain, then you're going to be anxious as a child, and you don't necessarily have that language capability to express those kinds of things, this strange, vague kind of pain or excited feeling or cold sensitivities, heat sensitivities. The provider may even uncover something like an abuse situation that could be causing the anxiety. So you really have to take a very thorough history with these patients. I was reading in the guidelines that NPs in primary care should refer to psychiatry if there's no improvement in symptoms in 8 weeks while attending psychotherapy and taking an SSRI. So your first-line treatments, if they're not effective, then it would be prudent to refer to psychiatry. You should refer immediately if their symptoms are severe, or if you're concerned with their safety, like suicidal thoughts or self-harm behaviors, or with suspected bipolar, because management changes with bipolar disorders. The NP would also be doing him or herself a favor by becoming familiar with the multiple screening tools for pediatric anxiety and knowing how to use these and implement these in their practice. Lastly, in my opinion, I do think NPs should be treating anxiety in the primary care setting, but it all comes down to their comfort level. I don't think any NP should be doing something that they are uncomfortable with or don't have the knowledge or don't feel equipped to be providing that level of care, but I certainly think it's something that we should all strive to be comfortable with, just because of how common it is and how much it can really affect someone's life and how frequently it presents in childhood and gets mismanaged, and then you see a lot of long-term effects when these kids aren't intervened upon when their anxiety first starts. It can lead to a lot of different problems in adolescence, young adulthood, and later adulthood. But I do think that NPs should know where their limitations exist and when to refer to psychiatry or when to refer to a specialist if they feel like they're in over their head or they're getting to a point where the patient would be better served in a specialty area. But in the end, patient first. We want to make sure that in the future they have no impacts related to anxiety on their learning, their social development, or their emotional health. But I think it's something that we should all strive to be confident with, just given how common it is and how influential it can be in a developing child's life.